We have world-renowned Dr. David Allie out of Lafayette, Louisiana with us, who has one of the largest outpatient labs with probably the highest volume in the region. And he agrees that more needs to be done earlier to get people to see a cardiologist.
Thank you very much. I'm a cardiac and vascular surgeon by my training that goes back 40 years. So my biases are both from a surgeon and more recently an interventionalist. So from the outpatient standpoint, we've started some of the first of these in our state approximately 4 years ago. That means as long as 5 years ago, most procedures to fix one's legs had to be done in a hospital, often overnight. The decade before, always open surgery. So within the last 4 years or so, we can now have technologies that are small enough, results that are good enough, that patients actually come in and go home within 4 or 5 hours. They receive as good a care as overnight stays. And in my career, which is 40 years, one of the most outstanding things that I have seen that really has been a game changer is the fact that over half of the patients that I treat, and this includes limb salvage, very advanced cases, we treat them the same day, 10, 15 at a time. The results are good. It's safe. It's now reimbursed by the government. And so it is a treatment that we should be offering more frequently. We should be diagnosing earlier. We can spend a lot of time on the history here. But at this moment, we know the statistics favor greatly, as Dr. Mustafa said, early diagnosis, early treatments. They are not all just stents or surgery. We have newer medicines. We have ways to prevent. We have things that we can add a stent plus a medication. So we have a lot of things differently now than just a decade ago. We need to do better education. Some of us have been trying to do this for many years. Congratulations on what you're trying to do right now, because it's right up the same alley that a lot of us have worked on.
So why is it that doctors, general practitioners, nurse practitioners, why are they so, I'm hesitating to use the word resistant, but I am not going to resist using the word resistant because I do feel it's the case. Why are they resistant to do more advanced testing when 40% of people who have heart attack, strokes, and amputation don't even know they're at risk until it's almost too late?
This is a mind-changing thing of education that takes time, and it's no excuses, but there has to be certain incentives, the way doctors are trained, the way that reimbursements are given. There's a lot of variables here. And the older mentalities are to wait till symptoms are worse before you do anything, because the treatments used to be high risk. Now they're very minimally risky. And in what I have seen is that we now have a whole new set of nurse practitioners, PAs, let's say non-MDs, who are actually point of care of a lot of healthcare. And I don't know that they are taught enough. I think that we need to do a better job in the schooling. There's got to be some incentives because healthcare, there is costs. The patients come. They are seen in a hurried fashion, and unless there's some incentive that the physicians or the nurse practitioners have, meaning the primary care physicians, their day is busy. They're not going to focus on the arteries, the heart, etc. They should. They do that. They need to do a better job. We need to educate them better. Healthcare, the government needs to. We even have newer treatments and rehab and exercise that have come out just this year.
Yes, talk about that.
Need to know about.
Yes, please talk about that. I think everyone would be interested in hearing about SET.
Well, in my practice, again, which is both a surgical and a non-surgical practice, I will see patients who will need bypass surgery, or they will need stents, or they will need some type of treatment, and then they need follow-up. The SET program has just been funded by CMS, and these are patients who have peripheral arterial disease that are diagnosed. There is specific criteria. It's been okayed by the American Heart Association and CMS, And we need to do a better job in all of our physicians, our cardiologists, and our surgeons. And after these patients are revascularized, they need to go in this set program. It is monitored. The outcomes have been measured. There's going to be improvements, and it is available to the patients, and it is paid for. And this is prevention, even after an intervention. So things are changing. I'm happy to see that, but it's not spread wide yet. We need to do a better job educating the American heart, physicians, conferences, these sort of things. It's available for the patients. It's got clinical and it's got economic benefits.
What does SET stand for?
It stands for a exercise therapy program in peripheral disease. Okay, and so what it means is, just like there is cardiac rehab after you have a heart attack, after you have a stent or bypass surgery, there is now the same therapy, monitored exercise that is available for peripheral arterial disease patients. And so that is what is new. It's been around, but not utilized and not paid for. So therefore, to make an impact, we have to get the word out to all healthcare providers that this is something that is good for your patients, especially PAD patients.
To lead by example, how are you planning to implement this with your patients? Is this something that the patients need to ask for? Is this something that you're putting together an entire program?
Well, we're going to do a lot of community education, number one, and I've done an awful lot of that. And this is one of the things we'll focus on in 2020. I have a large practice, so I have a large amount of these patients who already fall into that category. But without it being reimbursed, it's very difficult for them to do the travel, et cetera. So we're going to learn ourselves on how to do this. And we're planning within a new center that we're building to hopefully incorporate that and make a model that others can follow. So we're going to be learning how to do it ourselves. It is new, and just identifying the patients with any peripheral vascular disease. And again, the criteria are there by symptoms or by ultrasound or even by ABI or in an exam. A lot of patients will qualify for this, and we're going to start enrolling them and learning ourselves. It's brand new.
That's really exciting. So you have your endovascular treatments for both heart and for the legs. You have these cardiac programs, these rehab programs. What about biologics? What about pharma? We know a lot of cardiologists are all about statins. We know that patients are resistant to them because of the side effects. What's new and what's next? I am hearing that there's a newer trend to follow the route of other inflammatory disorders such as psoriasis and Crohn's disease with immunosuppressants, such as Repatha. What are you hearing, and what are you doing with your patients along those lines, if anything at all?
Well, again, having spent a lot of time taking care of the patients at the end, I've gained more respect for anything I can add to my surgery or my stents or primary care that has to do with medical therapy. Certainly, we know there's some advantage with cholesterol management and blood pressure medications like that. But I can tell you that this inflammatory process, or the role of inflammation in the entire body, and it's not just in vascular disease, it's all over in multiple healthcare issues. I can tell you that having looked at arteries for 40 years, I can see inflammation as a surgeon. I can see this there. So I have known about this, as have others. So there has been various attempts medically through the years to try to address this, whether it be steroids, whether it be injections, whether it would be balloons that are coated with anti-cancer drugs. In other words, a whole host of different medical therapies to address, let's say, inflammation or scar tissue that's in these vessels. And so some of the newer anti-inflammatory medications, like you're saying, Repatha, some of them for Crohn's disease. In other words, another type of anti-inflammatory medication, I think there's going to be a role for it. Now, time will tell. We would like these medications to help, let's say, delay or maybe even reverse cardiovascular disease. That is something we should seek. But even the ones who have the disease, because this is a aging process of a blood vessel. We have no cures. It's going to still occur. Let's say we place a stent I would like to be able to have a medication that makes that stent last longer, something medically that keeps the inflammation down. Therefore, our result is better. We fix one leg, we have the other leg to worry about. There is a lot of room for new medical innovations, let's say, not just technologies, but also medical innovations along with the technologies that have refined themselves, that have allowed us to do these procedures now in a few minutes and send the patients home. Be great to have complementary medications to go along with that in the next decade.
And you're very heavy in your discussion about the legs, and it just goes to show, our theme, sore legs can indicate your risk for heart attack, for stroke, and amputation. 1 in 20 people who are over age 50 actually have plaque buildup already in their legs. And that means 1 in 20 people is at serious risk for heart attack and stroke as well. So it's really important that when you go to your general practitioner, or when you go to your nurse practitioner, or even if you're intimidated by them, ask the nurse, please check the pulses in my legs. Right, Dr. Allie?
No question. And the statistics that you have given may be even worse. We know back to the Vietnam ages when there were autopsies done on teenagers that there was early streaking. So this is a part of life. It is part of the history of a blood vessel, and it's probably more prevalent than you mentioned. And we have more 80-year-olds alive today than we have 40-year-olds. So we have a huge population out there with cardiovascular disease that is there. We have no cure. It is progressive. All of these technologies need to be refined, and it is prevalent. It is prevalent. And heart disease, vascular disease, PAD, they go together one-on-one. As again, somebody who did heart surgery for 30 years, also vascular surgery in those same patients, I am used to seeing it every day in the same patient. It is the same blood vessel within the body. That's the way the Lord made us, and it's affected by the same ways and the same processes. So they have both. The physicians, the nurse practitioners, they need to have an eye out for this. There's even ways that you can have your patients, before the doctor or the nurse practitioner sees them, they can have a technologist, as a matter of fact, doing blood pressure measurements, ABIs, pulses of the leg before they even get to the doctor, to know something that before the doctor sees the patient or the nurse practitioner. So there's some way in the office that needs to be figured out. Each of these patients who walk into a doctor's office can have this done. It's focus, it's focus, it's focus.